Hello, everyone. Thank you for joining us once again for another Preconception Peer Educators Program webinar. My name is Teddy Owusu. I'm the program coordinator. Today we are joined by Dr. Lori Wilson, Howard University Hospital and College of Medicine Surgical Oncologist and Surgery Residency Program Director. She's also a breast cancer survivor who's had 2 different types of invasive breast cancer, 1 in each breast. Her breast cancer story is captured on film in the documentary Cancer, the Emperor of All Maladies. Today we're going to do something a little different. We'll show bits of the video from the documentary. So just to let you all know, you can only hear the audio from the from the video through your computer speakers. If you're on the phone line, you won't be able to hear. That doesn't mean it's just only on computer can you hear. Following Dr. Wilson's presentation, we will hear from Nicole Thompson, who's a genetic counselor at Howard University Cancer Center, where she helps individuals and families make important decisions about their health based on their genetic information. Nicole is also involved in genetic research and specializes in identifying and providing genetic services in minority and underserved populations, specifically regarding cancer, as well as sickle cell trait. Thank you ladies both for joining us. Today we will begin with Dr. Wilson, but before we get into that, please note that all lines are on mute. Will be answered following the presentations. We'll have about 10 minutes for Q&A. And without further ado, we will go ahead and hear from Dr. Wilson.
Great. Thank you so much, and thank you for the opportunity. I always like to have the opportunity to discuss breast cancer, but I think this is a perfect opportunity to really begin to think about breast cancer and how it is a part of exploring detection to diagnosis, and how important it is to understand everyone who's impacted by breast cancer. I just want to start off by giving you a bit of background on the breast anatomy. When we think about breast cancer, it's important to really think about the breast and that it's an entity that has multiple areas that are important in breast cancer. When we think about the healthy breast, we think about areas such as the duct lead from the nipple to the lobules, and the lobules in women who are after pregnancy, or where milk is formed. And those are the basic 2 areas that breast cancer occur. The duct being the most common type of breast cancer, which is an invasive ductal, and the lobule being the second most common, an invasive lobule. And this is just a picture of kind of from a front view that sort of gives you a perspective of how many ducts actually there are. There's somewhere between 10 and 15 ducts that come down to the nipple. So it's not just one duct from the nipple, and it goes to the lobules. The breast is also filled with fat. So anywhere there isn't a breast tissue structure, there's fat that sort of fills that space. And then in the underarm, or what we call the axilla, there are lymph nodes. And lymph nodes are small organs that sit underneath the fat in the underarm, and they sort of act like filters. You can sort of see that they're channels and they're connected to the breast. And basically, any fluid that sort of comes from the breast goes through these lymph nodes and gets filtered before it goes to the rest of the body. And it's important to know about these lymph nodes because lymph nodes are a potential area of spread for breast cancer, and we actually have developed a technique that allows us to figure out if there is spread to the lymph nodes as well as spread to the rest of the body. The ducts and the lobules are important in the overall constant change that occurs. The breast and the breast tissue are constantly changing as we go through the spectrum of reproductive health. whether it's puberty, a menstrual cycle, pregnancy, or menopause. Menopause being when the ovaries stop making a generous amount of hormones that in fact affect not only the uterus but also the breast. Menstrual cycle, of course, when young women start their period, and it's important to know about that timing, because anytime a young woman has a period that starts before the age of 11, it increases their risk. And so much of what we do in breast cancer is looking at the risk factors that go along with it. I don't ever want to neglect from including a self-breast exam. Self-breast exam is such an important part of knowing your body and knowing your breast. I know that there are definite things that you want to get accomplished from a self-breast exam, and using the pads of the first 3 fingers in a circular manner or an up and down manner, you're going to look for size, symmetry, shape of any abnormality. You're also going to look at the skin color, make sure that there's no changes, texture, surface appearance, and what does the nipple look like. Changes that can occur that are normal, tenderness, of course, especially around a reproductive time, such as being going through your cyclic hormonal changes as it relates to the menstrual cycle or during pregnancy. Lumpy bumpiness, that really is more about the amount of breast tissue. When women are younger, they have more breast tissue. As they get older and toward menopause, much of the breast tissue sort of shrinks, and you get more fat in the breast. And so you go from a lumpy texture to a less lumpy, softer texture. And breasts may get larger or more firm. The things that we worry about and that I worry about as a surgeon is when a patient comes to me and they talk to me about that there's a new lump that they found. And it's important to know that not every lump is a cancer, but something that's new is something that draws our attention. Something that is hard, single, firm, and most often it is pain-less. There's unusual swelling, warmth or redness of the breast, unusual increase in the size or the shape of one of the breasts, or that there's some dimpling or puckering of the skin. Those are all warning signs. In addition to that, we should know that 8 out of every 10 breast lumps are benign, which means that they are not cancer, they're harmless. But it's difficult oftentimes to distinguish which is benign and which is harmless. And that which is cancer. And so it is usually important for any identified breast lump to have some level of evaluation by a healthcare professional. The things that we look at, of course, are all the factors that go into the reproductive health, the risk factors, as well as a physical examination of the breast tissue. There are things that we see that are definitely normal breast tissue and normal changes, such as fibroadenoma found in younger reproductively active women. Fibrocystic disease is that lumpy, bumpy texture of the breast that is absolutely normal. Cysts can be found in the breast, and it's a collection of fluid. You can see it here. It oftentimes can go up and down, and the body can reabsorb this fluid, and it's just typically changes that are stimulated by hormonal shifts that come from the ovary. Nipple discharge can occur, and then of course the things that we worry about mostly is cancer. It's important for us to know that breast cancers occur at a pretty significant number in the United States. When we look at the estimated number of cancers in 2015, 231,840 women are estimated to be diagnosed with breast cancer. And we also have to be thoughtful that breast cancer doesn't just occur in women, that it also occurs in men. And so about 1%, and that would be about 2,350 men affected. And when we think about breast cancer deaths, we still know that breast cancer we know that breast cancer can be cured, but there are patients that do succumb to the disease, and we typically think about 30,000 women per year and close to 450 men per year. I think it's important to also look at how breast cancer has changed in other ethnicities. One of the most recent most recent data points that have occurred, especially with African American women, is that the number of new cases actually have risen to the same incidence in African American women as in white women, and that is something that is new, which means that there are more cases, and so it's pretty significant. When we look at the most recent data in African American patients, we see about 27,000 women who were diagnosed in 2013. And about 6,000 of those women died from the disease in 2013. And I think I'd like to stop here, and I want you to take a look at the video. I think it's so important that breast cancer isn't just a number, that it is about making sure that we understand that patients come with history and family and support, and that surgical oncology and breast surgery is an important part of the care of women.
Okay, Dr. Wilson, I will be uploading the video. Let me know if you can see it.
The following program contains mature dogmas in cancer therapy.
Once in someone's life that actually could save their life, and that by far I thought was one of the most
Natural dogmas in cancer therapy, that cutting more meant curing more. Almost as importantly, he had reminded the field of cancer medicine that treatment without understanding the underlying
How about you, Nicole? Can you see the video?
Could do enormous damage.
What happens in medicine and in science is
the hope that is needed to resist once in someone's life that actually could save their life. And that by far I thought was one of the most dramatic things about surgical oncology.
Dr. Wilson specializes in breast cancer, in research as well as in her practice.
Right now, the important thing is to make sure that you are feeling well and that you're doing well.
excited.
You're excited and you're nervous, and
So if you could just keep
I know that we can do that to you. Deep breaths.
Whenever we know that cancer is the diagnosis, we always want to make sure that we give all sides, and that you may not be cured, and that your cancer could progress to something that could end your life.
In the next couple of weeks, that's fine.
Hey, Dr. Wilson, back to you.
Okay, great. And so when we look at breast cancer, it's important to know that the lifetime risk of women is about 12%. So 1 in 8 women will develop breast cancer in their lifetime. Breast cancer typically is the disease of women who are postmenopausal, so after their periods have stopped. And the average age in most all comers is about 61 years old. When we look at African American women, they actually are diagnosed a bit early, around age 57 or 58. I think the important thing to to underscore is that breast cancer is curable, and we have from NCI estimates approximately 3.1 million breast cancer survivors in 2014, which is great news, I think. It's important to know it's the second most common cause of death. It's the main cause of death in women in 45 to 55, and 50% of cases relate to known risk factors. However, only 10% are associated with family history. When we think about risk factors, Nicole will talk more in detail, but I think when I think about it, I think about that gender is the most important thing. Being a woman is the #1 risk factor. And then age. The risk of developing breast cancer increases with age. And when we think about when most women are diagnosed, they're over the age of 50, and that's about 3/4 of patients. It's important to know the demographics, ethnicity, kind of where you are, what other factors go along with who you are and what you bring to your history and your family history, your reproductive history, your environmental factors are also important. So really we're talking about gender, we're talking about age, we're talking about whether you've had a breast biopsy in the past that has been atypical. Things that such as family history, personal history of breast cancer, your reproductive risk, when you've had children, if you've not had children, also changes your risk. Obesity, we know that physical inactivity, alcohol, and exposure to radiation also increases your risk. And when we think about breast cancer, we think about what are the tools that we have. And right now there's a big shift to when should these tools be used for evaluating breast cancer. And the true key is whether a woman is normal risk. And normal risk are women that don't have a significant number of these risk factors that increase the likelihood that they're going to develop breast cancer. We have a way of looking at that. When we find women who are under the age of 30 that have a new breast lump, we typically use what we see on the right side, and that's ultrasound, and that's a picture of ultrasound. And on the left, we use mammogram. And mammogram really is a breast x-ray. It's the single most effective way of detecting the earliest stages of breast cancer in women greater than 35 years old. As women age, as we talked about, they have more fat in their breast, and so mammography gets better as we age. And it can uncover unexpected problems without symptoms, and that really is the key. Some pressure is needed to get the best picture and the clearest picture, and so many women find that there is some pain or discomfort that goes along with it, but usually that's short-lived. And why is it important? Because before mammography, when we think about mammography, it really sort of got ushered in the 70s to 80s. Before that, women were presenting with breast cancer with breast cancers that were as big as 5 centimeters. When we look at breast cancers today, if someone presents with something that's 5 centimeters, they're in a later stage of breast cancer. Most had lymph node metastasis, which means that you're in a later stage. And the 5-year survival at that time was about 58%. And so mammography really changed the way we dealt with identifying those changes. And so when is mammography needed? It's needed when we need to check a mass, to check a breast change, every year over the age of 45 to screen when you're normal risk, and even younger if you have a strong family history or some genetic changes that make you more at risk. I think that this is a good example of what patients often ask me, what does breast cancer look like? So this area, the white area in the right lower picture is what a breast cancer looks like. When we think about breast cancer, there is a spectrum of breast cancer, whether we're talking about the initial normal cells. You see that there's one layer, it sort of goes around the duct. As things get more abnormal, you see a loss of that normal anatomy. And then when you get down to invasive breast cancer, you see that it actually it goes across that membrane that has normally holds everything in place. How do we find out more about it? We use what we call needle biopsies, and needle biopsies help us to not have to go to surgery. So we take a sample of it and we look at it under the microscope. If a breast cancer comes back as a breast lump comes back as a breast cancer, then we may need to move on to lumpectomy. And lumpectomy is removal of the breast cancer itself with a normal appearing breast tissue around it. Our goal is to perform it in the operating room and let women go home. The vast majority of patients can have breast conserving therapy, but in a small number of patients, we need to remove the entire breast, and that is called a mastectomy. However, when we do that, we want to make sure that we reconstruct the breast at the same time if possible, and we can do that with tissue from the patient or implants, which are made of salt water or silicone. And this is just an example of what in the center, what a normal breast slide would look like. This is sort of a lobule. These are little ducts and lobules, and this is a duct here. And you can see here, this is actually a duct that's filled with a non-invasive breast cancer. It hasn't broken through that wall there. And then here is an invasive breast cancer, and you notice it loses all of its normal architecture. Ultimately, we look at the tumor markers to tell us about how aggressive the tumor is. And we also look at the edges to make sure that the edges around the breast cancer are free of cancer, so that women don't have to worry about it coming back in the same place. An important technique was developed called sentinel lymph node biopsy. Its goal is to identify those lymph nodes we talked about underneath the arm to make sure that there's no evidence of spread. So we inject a blue dye, and then this actually is a lymph node that has taken up that blue dye. And what we find is that the lymph nodes actually, in their normal anatomy, will take up blue dye sort of in a sequential fashion. So one will take it up first, and that, of course, is the sentinel lymph node, followed by the others. And so we remove one or two lymph nodes that are the first draining lymph nodes. And our goal, of course, is to make sure that we are able to keep breast cancers from metastasizing, which means leaving the breast tissue and going other places like the lymph nodes or distantly to the body. Our 5-year survival rate, if in stage 1, which means a very small breast cancer just found in the breast, is about 96%. Stage 2 is a slightly larger breast cancer with typically no findings in the lymph nodes. Stage 3 is usually a breast cancer that's either a larger breast cancer or a breast cancer that is a moderate size but also has gone to the lymph nodes. And then stage 4 means that it's gone to other places outside of the lymph nodes, to other parts of the body, whether it's bone, liver, lung, or brain. And when we look about these 5-year survivals, we think about survival in sort of 5-year increments. And so at the end of 5 years, 96% of stage 1 patients are alive. At the end of 5 years, 82% that have been diagnosed. At the end of 5 years, 53% of stage 3, and at end of 5 years after diagnosis, stage 4 patients, about 5 to 18% of them are going to be are going to survive. And so it is so incredibly important that we diagnose breast cancers early, so that we can identify those patients and get them started on treatment so that they can have the best possible outcome. And surgery is not the only thing that we use. We work in a multidisciplinary team to work toward breast cancer not coming back in the breast or not coming back in the whole body. And so there are other treatments that are tailored to the patient. Radiation therapy works directly on the breast and reduces its risk of it coming back in the breast. Chemotherapy treats the whole body, and not every patient gets chemotherapy, but for those women who have breast cancers that prove to be more aggressive, typically get chemotherapy. Hormonal agents, which means it's a medication that blocks the effects of hormones, because what we find is that hormones like estrogen, progesterone increase the likelihood of breast cancer cells growing, and so we block those mechanisms. And each therapy adds the reduction of disease coming back, and so they typically work in conjunction in reducing risk. Is it possible for us to make an impact? There is. There are things that we can't change, gender, age, those sorts of things, but making sure that we eat a healthy diet that are lower in fats, that we try to keep our weights into normal weight range, that we are physically active. The current recommendation is 150 minutes of moderate activity per week, and you can split that up in any way you like, or 75 minutes of really vigorous activity per week, and reducing any exposure to radiation. And I never want to neglect from saying it's the most important thing is really talking about it, being well informed, asking questions if diagnosed, making sure that you know all the risk and benefits, how are the therapies, and how should they be individualized and tailored for that person who has the diagnosis. It's important for us to know the context. Where patients come, what support systems, and what their goals are. And then it's a collaboration. We, from our perspective, our team typically works with our patients to understand what their goals are, making recommendations and tailoring the treatment plan. And so I think this is a good time for us to see the second video from Emperor of All Cancer, Emperor of All Maladies.
Okay.
The following program contains mature content which may not be suitable for all audiences. Viewer discretion is advised.
Timing?
Tonight on Cancer, the
40.
Emperor of All...
That we were playing that causes cancer. We
Using cigarette sales.
They're studying, but smoking and cancer. But cigarette companies hid the evidence from
43.
the public behind a barrage of pseudoscience. Shelf.
43 minutes.
At least he tasted it.
You're a funny boy. You know that?
Mommy likes cherries.
It's been a month since Lori's diagnosis, and her 20-week regimen of chemotherapy has begun.
Likes them. Yum, 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 yum. I got you! Yes.
My wife, Lori.
Hey, how you doing? Nice to meet you.
Good to meet you.
Like each other the most? I go first. Yeah.
My husband actually is going to shave his head with me, and so we will, until my hair grows back, we'll both be bald together.
Wow.
He's my rock. He's been there for everything.
He's looking good.
Y'all forget I've been bald-headed before, 20 years ago. Yeah, before Lori and I got together in the first winter when I grew my hair. And then Lori liked my hair when I haven't shaved it since.
Oh, what a story.
Sweet.
So cute. Right, next.
Oh,
Yeah.
let's see.
You can take it all. Okay.
You okay?
It'll be okay.
into the why me, because so much of cancer is not predictable, is not set on family history or any feature, and so absolutely could be me.
Hey, Nene. You recognize Mommy?
I have a 19-month-old, and I want to see my son grow up, see my son get married and go to grad school, and all the good stuff that we expect for family. And with this diagnosis, that's a more difficult thing to see.
Am I back?
Dr. Wilson?
Yes. Okay.
Oh.
So, yes. Um, so as you see, I'm a breast cancer survivor, and my story is a story like so many women. In 2013, I was diagnosed with breast cancer. It was different because I was diagnosed with two different types of breast cancer and two different breasts, and went through aggressive treatment, which included chemotherapy and radiation and surgery. And I'm very passionate about the need for additional research, additional treatments, additional screenings. What we know about our patient populations that we see is that breast cancer can be a different cancer in some ethnicities. And what we do know about breast cancer is that it's curable. However, we need to find it early to make a difference. And so hopefully by seeing some of the clips that we showed today, that it makes it more than just a diagnosis that you've heard about, and hopefully that it's something that we can have a significant impact, especially in the next several years. So I think that I will wrap up there and give Nicole Thompson an opportunity to talk to you guys too.
Okay. And thank you all for bearing with us. This is our first time doing video during one of these webinars, so sorry for the audio issues. But whenever you're ready, Nicole, we're waiting and listening.
All righty. Okay, can you all see everything?
Yep, looks good.
Yes.
All right. All right. Thank you all so much for having me, and thank you, Dr. Wilson, for sharing your story. And I just want to bring in the perspective of genetic counseling when it comes to a diagnosis of breast cancer. So I just want to share, the knowledge that I have with all of you, so what you should know and what you should also share with others. And so what is genetic counseling? A lot of people haven't really heard of genetic counseling unless they've had a family member go through it. or unless they've gone through it themselves. But genetic counseling is basically a process that helps people to understand and adapt to genetic diseases and conditions. So what genetic counselors do is we interpret family histories and medical histories from a person to determine if they have a chance of developing a disease or a higher chance of a disease recurring or coming back in a different body part, such as cancer. We also educate about how diseases are inherited, what tests are available to determine if they actually have a hereditary condition, how the condition can be managed, even prevented, and then also what resources are available and even research studies or opportunities. And then we also counsel to promote informed decision-making. So we try to take all of the pieces of the puzzle and bring them together to help the patients figure out what they should actually do as far as managing their hereditary cancer syndrome. So genetic counselors, we play a role in many different arenas, primarily, as we're going to talk about today, in cancer, where we identify individuals who have hereditary cancer syndromes, which we'll talk more about. We also are in prenatal, where we're talking with women and husbands and wives who may be carriers for conditions, like maybe carriers of sickle cell trait and want to know if their child might have sickle cell disease. We also work in pediatrics with children who are very sick and they've had every single test available, and genetics sometimes is the last on the list, but it's able to figure out what's actually causing the condition for the child. And then the same for cardiology, neurology, adult onset, pharmacogenetics, which is a very new area, and then reproductive, such as in vitro fertilization or IVF. And so about genetic counselors, we're employed at most cancer centers nationwide. We're becoming a very integral part of the team, providing resources that could definitely change a patient's management of care if we find out that they do have a genetic mutation. And we also serve as educators in the community. Genetic counseling is also becoming standard of care for any patients who meet criteria for counseling and testing, which we'll go over as well. And so who's referred for genetic counseling? So if you have been diagnosed with cancer, if you're diagnosed age 50 or younger with cancer, you're definitely an appropriate candidate for genetic counseling and genetic testing. Anyone that's diagnosed with ovarian cancer at any age, as ovarian cancer is a pretty rare cancer to be diagnosed with for women, they're good candidates for genetic counseling and testing as well. For anyone that's had bilateral breast cancer, so that's breast cancer in both breasts, they're candidates. For anyone with rare cancers or rare tumors, they also are candidates. Or anyone diagnosed with different types of cancer. So you may have been diagnosed with breast cancer and then diagnosed 5 years later with colon cancer. Or anyone that's diagnosed with cancer, they could be diagnosed over age 50, but also have a family history. That also makes them a good candidate for testing and counseling as well. And so if you have not been diagnosed with cancer, but you do have a family history of the following, then you also would be a good candidate. So if you have not been diagnosed, but say your mother was diagnosed at 50 or younger, or you have a sister or an aunt with ovarian cancer, or someone in your family has had breast cancer in both breasts, or rare tumors, or diagnosed with many different types of cancers, and that would also make you a candidate for counseling and testing as well. And so these are just some guidelines that we follow in oncology. It's the National Comprehensive Cancer Network's guidelines. So if any individual across the board just meets this criteria, then this is how a physician would know that, okay, this patient should be sent in for genetic counseling and genetic testing to figure out if their cancer is due to a syndrome or if it's something that's hereditary. And so what happens during the genetic counseling sessions? So the first thing we do is we talk about your health history. We talk about everything, were you diagnosed with cancer? When were you diagnosed? Do you have any other medical conditions? When was your last mammogram? Have you ever had a colonoscopy where any colon polyps removed? Have you had any surgeries? We try to get a really good picture of what's going on for the person medically. And then next, after that, we talk about their family history. Family history is extremely important when it comes to genetic counseling and genetic testing because we're all directly related to our relatives through our genes. So if we have family members that have certain conditions, then there's a higher chance that we could also have that same condition. So we try to get 3 generations of relatives, so starting with the individual and working our way up or our way down. And we try to find out who's been diagnosed, on their mother's side or father's side, at what age, and then with what type of cancer. And so this is an example of a pedigree or a family tree, as we call it, and we have to get both sides, the maternal side and the paternal side. So maternal is mother, paternal is father. And so squares are men, and then circles are women. So this arrow here is pointing to, let's say that's our patient. So he has two sisters here. This would be his father. So his father's side here is in this blue. So this would be his father's brother, his father's sister. This would be some of his cousins here. This would be his paternal grandparents. And then here's his mother. Here's his mother's sister. And here his mother had a son with a different father. And then here are his mother's parents. So we try to get 3 generations. So here's the first generation with the patient, and then here his parents' generation, and then here are his grandparents, which is the 3rd generation. And this helps us to see how cancer is traveling throughout the family, whether it's coming from the mother's side or from the father's side. And so what causes hereditary cancers? So it's actually something that happens in our genes. So it's important to note that the majority of cancers, about 70% of cancers, are sporadic. They're just random. They happen by chance. The older we get, the higher our chances are of developing cancer. Then the next biggest part of cancers are familial cancers. And that's where we see more cancer in a family than we should. And that could be for a host of reasons, where maybe family members are living to be much older, or environmental or lifestyle factors. So if a family member or lots of family members have worked in coal mines or have been exposed to some type of chemical or radiation, or heavy smokers or heavy drinkers, there may be different kinds of cancers popping up in the family. So it may look like there's a strong family history of cancer, but it's not necessarily hereditary. And then the smallest pieces of cancers are about 5 to 10% of cancers can be hereditary. So that's where you're just born with a higher chance to develop cancer than anyone else because of something going on in your genes. And so just a quick, genetics lesson or biology lesson. This here is a picture of a cell, and we have tons of cells in our bodies. We have skin cells, bone cells, blood cells, hair cells, all types of cells. And inside of cells is where you're going to find chromosomes. And chromosomes are pretty much the instructions to make us who we are. So you get 23 chromosomes from your mother, you get 23 chromosomes from your father, and when they come together to make us, we get 46 chromosomes. So these chromosomes, they contain all of the information to make sure that we can see, hear, have 2 arms, 2 legs. And if you're to unravel these chromosomes, that's where you're going to find genes. And every single gene has a responsibility or has a job. So some genes are responsible for seeing, some genes are responsible for heart development, and some genes are actually responsible for protecting us from cancer. And so genes work by these letters here called DNA, which is ACTG, ACTG. So every single gene has a very specific DNA code in order for that gene to work. So if just one of these DNA letters is changed or out of place or duplicated or deleted, it could cause that gene to no longer work. So if it's a gene that protects us from getting cancer and one of these DNA letters is misplaced, then that gene is no longer able to function the way that it normally would, which would increase our risk of getting cancer. And so we pretty much talked about what a gene is, but let's say a gene is pretty much like a recipe. So just like a recipe tells you how to bake a cake, a gene tells your body how your body should perform or how various functions should perform. So a mutation is a change or an error in the recipe. So imagine if we put 1 cup of baking soda into our recipe instead of 1 tablespoon of baking soda into our recipe. The cake may not come out the way that it should. And the same thing can happen with genes or genetic mutations. And so we're going to talk a little bit about the BRCA gene mutations, which is probably the most heard of genetic mutation, BRCA gene. And so this is an example of how mutations can occur. So let's say, for instance, this is the BRCA1 gene and this is the BRCA2 gene. BRCA stands for breast cancer gene 1, and then the breast cancer gene number 2. And so let's say this here is the genetic code that's needed in order for the BRCA1 gene to work. And let's say this is the code that's needed for the BRCA2 gene to work. What can happen is these two T's here can be completely deleted, and that's considered a gene mutation. So now this gene that usually protects us from getting breast cancer is no longer working. Or what could happen in BRCA2 is that this TTA here has been picked up and moved to the very end. So this is also considered a mutation, and this may cause the BRCA2 gene to no longer work. And so the BRCA1 and BRCA2 genes, we all have these genes. So I'll often hear people say, you know, do I have the gene? Do I have the gene? We all have the gene. The genes are protecting us from cancer, but the issue is the gene working? So these genes are in every single cell of our body. They're inside of our bodies from birth. They work to protect us from certain cancers, and those cancers are breast, ovarian, prostate cancer for men, and then pancreatic cancers for men and women. And so if someone has a mutation in BRCA1 or in BRCA2, they have a syndrome called Hereditary Breast and Ovarian Cancer Syndrome, which means that they have a higher chance to develop breast cancer or ovarian cancer or any of the others. So some of the main features that I see when someone comes into the clinic for me to determine if they actually need genetic testing is that they'll have triple-negative breast cancer, which is a very aggressive type of breast cancer. That's the TNBC. Or breast cancer diagnosed age 50 or younger, or they may have ovarian cancer. I've even had men with breast cancer, that is possible, pancreatic cancer, or someone that's of Ashkenazi Jewish ancestry, that the population has a higher chance of having a genetic mutation. BRCA genes, gene mutations, are actually autosomal dominant. So what that means is that if someone carries a BRCA mutation, there's a 50% chance that they could pass it down to their child. And that means that they've inherited from their mother or from their father. And so now we're going to talk about a few myths in regards to genetic testing. There are a lot of different things that people have heard or different things that people believe that may not necessarily be true regarding genetic counseling and genetic testing. So one of those is that cancer runs on my father's side, so there's nothing that I should worry about, which isn't necessarily true. So because it's an autosomal dominant condition, it can be inherited from mother or father's side. So these purple-looking sticks here, these are chromosomes, and this is a close-up view of what chromosomes look like in all of our cells. And so we have 23 pairs. We get one from our mother, and we get one from our father. So if we're looking here, and we assume that this here is a BRCA gene, it says here that the father is affected. So this purple area is considered a gene mutation. This orange area is considered the gene that's working. So the mother, she's unaffected. So for every single pregnancy that they have, there's a 50% chance that it could be passed down. But the only way to know for sure is to actually be tested. So it shows here that in this instance, there's a 50% chance that he could pass this down. So he can pass down the one that has a mutation or the one that does not. So to this child, he passed down the one that had the mutation. So this child is affected. For this child, he passed down this one. For this child, he passed down the one that's unaffected. And then for this child, he passed down the one that is affected. For the mother, it doesn't matter which she passes down because both of them are working. So this shows that you can actually inherit mutations from your father's side of the family. So if your father has had cancer or his sisters or brothers have had cancer, it still is significant for you. And then this is just explaining, again, male breast cancer is definitely something that should be thought of when we're talking about genetic mutations, specifically in the BRCA1 and BRCA2 genes, or BRCA1 and BRCA2. Another myth is that I already had cancer, so I don't actually need genetic testing, which isn't necessarily always true. So this is a chart explaining the different types of cancers and who could actually have a higher risk of cancer. So if someone has had breast cancer, their chance, and they actually have a BRCA1 mutation, their chance to get breast cancer is between 50% to 80%. Or if they have a BRCA2 mutation, it's between 40% to 70%, when the general population is only at 12%. So the risks are much higher. But if they've had breast cancer and they also have a gene mutation, there's a higher chance that they can have a second breast cancer or even ovarian cancer. And the risks vary depending on which gene is actually mutated. So you may have been diagnosed with breast cancer and been treated, but if you have a gene mutation, there could be a risk for a second cancer. So that myth is actually busted. Just because you've been diagnosed, that does not mean that you no longer need screening or testing. And so some of the possible test result outcomes that you could have if you actually undergo genetic testing is the result could be negative. And that means that everything is looking great in those genes that were tested, that you don't have that hereditary cancer syndrome. However, we do know now that there are other genes that are increasing the risk of cancer besides BRCA1 or BRCA2. So it could be in some other gene that wasn't a part of that particular test. There are also things called variants of uncertain significance. So that's a unique change that each of us may have in our genes, and it's not yet known what that change actually means. And then the third could be that it's actually positive, and that means that there is a genetic mutation in BRCA1 or BRCA2 that is increasing the risk for several different types of cancers. And if we find that for one person, then we try to offer testing to family members and to relatives because they could also carry that same mutation. And if they've not been diagnosed with cancer, having this information ahead of time could do just as Dr. Wilson was saying, it could lead to an early diagnosis where we know that the outcomes are much better. And so this is an example of a test result for someone that actually comes back positive for a genetic mutation. And if we find out where that exact mutation is, then we can then test the family for that same exact mutation. So some may say, I don't want to know because there's nothing that I can do. Why find out if I have a genetic mutation if there's nothing that I can do about it? And there actually are options available if we find out that you actually have a mutation. So one is more frequent and earlier screenings. So if we find out that someone has a predisposition to colon cancer, then we can then offer a colonoscopy at a much earlier age than waiting to 40 or 50 years old. And they can have their colon polyps removed, or even if we find out that someone is at an increased risk for breast cancer, they can have mammograms or MRIs done more frequently and at earlier ages. We can also consider the option of bilateral mastectomy or oophorectomy. Some women who actually are newly diagnosed with cancer and find out that they have a genetic mutation and have a high chance for a second breast cancer or for ovarian cancer, this may also be an option for them as well, in addition to the option of reconstruction. And then also there's the option to take certain types of medications, which have been shown to reduce the risk of breast and ovarian cancer by 50% or more. And then should you discuss these results with your family members? Absolutely. Genetic information is not specific for one person. It actually impacts the whole entire family. And so what if you didn't test positive? That's excellent news. So that means that the result could be negative, where you have not inherited a genetic mutation, or it could be a variant of uncertain significance, which is where we don't have a lot of information about that particular change at this time. But research is ongoing, and the labs are constantly working to reclassify these variants. And the majority of people that come in for genetic testing will actually have a negative result or will have a variant of uncertain significance. But now that genetic testing is progressing, we do know that there are other genes that increase the risk of cancer. And so how do you know if your genes aren't working? So these are some things that you can consider. Is if you or any of your family members were diagnosed with cancer, breast cancer before age 50, if you or your family members have been diagnosed with ovarian cancer, if you have any relatives with male breast cancer, or if you or any of your family members were diagnosed with more than one breast cancer, or breast and pancreatic, or breast and thyroid, or breast and any other cancer? Or do you have two or more relatives on the same side of the family with breast cancer that were diagnosed before or after age 50, either or? Are you of Ashkenazi Jewish ancestry? Or is there a known genetic mutation in your family? If there's a known mutation in your family, then that automatically makes you a great candidate for testing to find out if you have a risk of developing cancer as well, a higher risk. And so we know now that when it comes to genetic mutations, there are several different types of cancers that can happen from one gene mutation. You can have a gene mutation and have ovarian cancer. Another relative can have that same mutation and have colon cancer. So now what's available, what's new in genetics is that there are these panels that can be ordered, especially for individuals who have a family history of several different types of cancers. This panel would actually be most beneficial. So what this is showing here on the left-hand side are genes. So all of these genes here on this list are genes that actually work to protect us from getting cancer. So these here, the syndrome, this is the name of the syndrome that's associated with the gene. And then these here are the types of cancers that are associated. So we have breast cancer, ovarian cancer, colon, endometrial, which is uterine, melanoma, which is skin cancer, pancreatic, gastric, prostate, and then other cancers. So we know here that we just talked about BRCA1 and BRCA2, and then hereditary breast and ovarian cancer syndrome. We know that there's a higher risk for breast cancer, a higher risk for ovarian cancer, and there's also a risk for pancreatic cancer, a slight risk for melanoma with BRCA2, and then there's a risk for prostate cancer. But say you have other cancers in your family, such as colon cancer, and you have uterine cancer in your family. You may also want to include in your testing all of these genes. And then we also know that these two genes are not the only ones that increase the risk of breast cancer. We also have all of these genes here that are known to be associated with breast cancer. So rather than singling out only BRCA1 and BRCA2, it may be best to incorporate an entire panel to meet the needs of other relatives who've been diagnosed with other cancers, or to see if it's a different gene that's increasing the risk of breast cancer. And so this is just another table just really illustrating pretty well how other genes are increasing the risk of breast cancer and other genes are increasing the risk of ovarian cancer. So it's very important to try to cover the board in regards to genes rather than just singling out one or two genes, because you never know which one could actually come back showing a genetic mutation or not. And so what's actually needed for genetic testing? I get that question a lot. And it used to just only be blood, but now it's blood or saliva. So you could do a blood draw or give 2 tubes of saliva. Some labs require 1 tube, and they could do the genetic testing that way. How many genes can be tested? We just talked about it could be 1 to 2 genes or 40 or more genes that can be tested for. And results are usually back within 2 to 3 weeks, but it could take a little bit longer if we're doing a bigger panel. And most importantly, is it covered by insurance? And that is yes, it absolutely is covered by insurance. There are some insurance barriers when it comes to Medicaid and Medicare, but there are so many labs offering testing now where if one lab doesn't work, then there are other labs who have programs that will work with patients who have Medicare or Medicaid. Results are given to the patient and also to their doctors, so that way their doctors can know if they have a higher risk of cancer, and the doctors will be able to, write the referral for them to go ahead and get their mammograms done more frequently or get them done earlier at an earlier age. And then we also encourage the individual to share the results with their family, which is most important, because we're trying to prevent the burden or reduce the burden of cancer amongst all these families who have these hereditary predispositions to cancer. And so what are the benefits of genetic testing? And so the benefit of genetic testing is that your care is tailored directly to your own specific genetic makeup. So if we know what you're at risk for, we now are able to help you make the best medical management decisions. So that could be surgically, where you may consider more aggressive surgery, or it could be increased surveillance, that's having more procedures done more often, like mammograms and colonoscopies, or transvaginal exams. Chemo prevention, which is medication, or as we talked about, risk-reducing surgeries. And then there's also a very important opportunity for family members to take action, so they can get tested early and find out that they have a predisposition before they've ever been diagnosed with cancer. And they'll have access to screening options, earlier detection, prevention, and it also helps with family planning. And so testing can be for affected or unaffected individuals for hereditary cancers. So if they're affected, it can determine the cause of the disease. It can also provide us with a risk assessment to know what else they may be at risk for. It may also identify risk for other conditions that may not have been thought about if they didn't go through the testing process. And then those who are unaffected will know prior to diagnosis and have that key opportunity for early intervention. And this is my contact information here, so I'm not sure if you want to take it back to Teddy.
Sure. Thanks, Nicole. So right now we're going to begin our Q&A portion. This will be about a 5 to 10 minute portion, so you all can start asking your questions. Please use the questions box, and we can get started excuse me, with our first question. I guess either of you can answer this, but I'm going to direct it to Dr. Wilson. First question is, can men get mammograms, and can you give us some known causes for male breast cancer? Dr. Wilson, is your line on mute?
I think, yes, thank you.
Okay.
That's a great question. When we think about the way that we evaluate men, we do it very similarly to women. And so we do mammograms for men. I know that oftentimes we think that men don't have a lot of breast tissue, but they do have some. And so we use those two plates to identify any changes that might be there. We would probably also do some additional diagnostic imaging with ultrasound. And one of the techniques that has been proven to be very useful is also MRI. MRI is an imaging technique that uses magnetic resolution to look at anatomy. And it doesn't have any radiation, and it gives us a lot of information about the tissue, the blood vessels, and the nerves. And so reasons for breast cancer, I think Nicole has really underscored a tremendous amount. Much of our concern when we see a man with breast cancer is that there is a genetic mutation that might be associated. And then other risk factors that go along with those patients can also be familial if there's not a noted genetic relationship. Nicole, do you want to add anything else?
No, that's great.
Okay. So next question we have, I think it was on one of your slides, Nicole.
Okay.
Why is having Jewish ancestry considered a risk factor?
Right. So the Jewish population, they were actually screened very early on in terms of genetic testing, and especially in regards to BRCA1 and BRCA2. There were several studies done in the Jewish population, and it was found that Ashkenazi Jews specifically have about 3 genetic mutations that increase their risk of breast or ovarian cancer. So if you're actually of Ashkenazi Jewish ancestry, there's a specific panel that's utilized specifically for that population that will target the genetic mutations that tend to occur most often in that group. So we know that specifically for the Ashkenazi Jewish population.
Okay, thank you. Next question. Can diet, in addition to genetics, impact your chances of breast cancer?
Diet, it in several ways. Diet in what we've seen is a correlation between low-fat, healthier diets and being able to maintain a normal body mass index, which is a normal body weight in relationship to sort of your height. And so those have been proven to when you adhere to those and you're physically active and you have a normal body weight, that you can improve your risk factors.
Okay, next question. A recent article in JAMA noted that there is a low percentage of patients getting pre-testing genetic counseling prior to undergoing genetic testing. This question is directed to you, Nicole. Do you see that with the use of extended gene testing, payers are requiring a genetic counseling note or copy of the pedigree to justify their authorization for genetic testing?
Yes. So just to address the first part, I think that that's definitely key with the pre-test counseling. I think pre-test counseling is absolutely important before ordering genetic testing. Genetic test results can give you so much information. And as I mentioned before, it doesn't only impact you individually, it also impacts your entire family. So if one person finds out that they have this predisposition to cancer, that means that their brothers and sisters have that same risk, and that means that their parents have that risk and their future children will have that risk. So when they make this decision to obtain that information, they're also kind of opening that door for their relatives as well. So it's definitely important to have the genetic counseling to go over all of that information. Also, with these panels that we're ordering, we're now finding out if you have risk for a totally different type of cancer or some other type of syndrome that you weren't exactly diagnosed with at this time. So with genetic counseling, we go over that information as well, so you're not blindsided when you get these results back saying that you have a risk for thyroid cancer, and we're here talking about ovarian cancer. So the genetic counseling is extremely important in regards to the pre-testing. Also, in terms of insurance coverage, pretty much almost every insurance company, they do require some type of justification for genetic testing. It is an expensive procedure, I would say. It can range between $1,000 to over $5,000. So, of course, for the insurance companies to cover it, they want to make sure that you are meeting NCCN guidelines or their guidelines, which are based off of NCCN guidelines. So the importance of that family tree that I do with every patient is going to be beneficial with getting their testing covered. So when I send in the pedigree to the insurance companies, they're able to look at the individuals and see that testing is justified for the person that they're providing coverage for. So that it definitely is an important factor.
Dr. Wilson, what type of treatments did you undergo in your battle with cancer?
So I was diagnosed after my son was born. He was a year old, and I breastfed. And what I found is that one of my breasts didn't go down to the size I expected after I stopped breastfeeding. And so I started out with my diagnostic studies. So I had a mammogram, an ultrasound, and MRI. The results showed that I had an invasive ductal, which was triple negative, and I also had an invasive lobular cancer. And so I went on to start off with chemotherapy. So I had a 20-week regimen of chemotherapy that was started, and then I took a month off. I had my double mastectomy that was done with reconstruction, and then I took a month off, and then I had chest wall radiation. So I did 6 weeks of radiation as well. And now I'm on a targeted anti-hormonal medication to reduce the risk of it coming back.
Thank you. And we have a question. How would you approach women who don't feel that they're at any risk or feel that they are at very low risk just because they're young?
So I think it ties in for me just making sure that we're communicating and that we're always sort of assessing where patients come and what their goals are. Young women, currently the recommendations for normal risk, which means that there are no risk factors that are elevated. There's nothing from a familial standpoint, and there's no risk, no thought of gene mutations for that person, that they start mammography at age 45. But that it's important for patients to understand about their own body, so self-breast exam is helpful. And then just making sure that every time that I have an opportunity to talk to young women, that I hope we communicate the potential risk for every age group, as early as age 20, being diagnosed with breast cancer. It's less likely, but definitely is possible. And also, I think it's also key for people to know that 70% of patients don't have any family risk or any gene mutation that's been identified. So the vast majority will not come with any understanding that they're actually at risk until they have a breast cancer.
Thank you very much, Dr. Wilson. Nicole, I have a couple of questions for you. In occurrences, in familial occurrences, does it tend to be homogeneous among all the women or all the men, or are there occurrences in both the men and women in the family? And the second question is, where can we access or get copies of that MyRisk checklist?
Yeah, so it doesn't. So it doesn't happen in all the women or in all the men. So they're autosomal dominant conditions. Most of these hereditary cancer conditions are autosomal dominant. So that means that there's always a 50% chance of it being passed down with every pregnancy. So there's a 1 in 2 chance that you could have a gene mutation if a first-degree relative has one. So for instance, if my mother has a BRCA1 gene mutation, there is a 1 in 2 chance with every pregnancy that she would have for that child to have the same exact gene mutation. So there may be one person out of 6 siblings that has it. There may be all 6 that have it, or there may be 3 that have it and 3 don't. It really varies. And the only way to know for sure if you have a mutation is to actually undergo testing. And having a mutation, let me also say, does not guarantee that you will get cancer. It increases the risk. So if someone has a mutation, it's not a 100% chance that they will definitely get cancer, but their risk is higher. For the first question. And then the second question is where they can find the MyRisk panel. So there are a few panels. MyRisk specifically is through Myriad Genetics. So you can go to, I believe it's Myriad Pro. It's myriadpro.com. Myriad is one of the genetic laboratories that offer genetic testing that has a panel. Another is Ambry Genetics, AMBRY Genetics. I think theirs is ambrygen.com, and they also have several different panels that they offer for genetic testing as well.
Okay, great. Thanks so much, Nicole. And finally, Dr. Wilson, are you familiar with the ACA's recently updated mammogram recommendations? And if so, what are your thoughts on the changes?
Yes. Well, it's the American Cancer Society changed their current recommendations for in a couple ways that I think are important for normal risk women. For normal risk women, they currently recommend going from a mammogram at age 40 every year to age 45, and then every year after that. They also made changes in the role of clinical breast exam in normal risk women as well. That was not something that was is needed. My concern is that normal risk is oftentimes a vague term to many of my patients, and so knowing whether you're normal risk or not really takes some education and takes some time with a healthcare provider that's going to be able to go through those things with you. So I think that it's important to know what your risks are, what your risk factors are, and where you find. I think it's important to advocate for yourself. What I do know, though, is that in my patient population, my population of patients actually don't represent the majority. The predominant ethnicity of my patient population is African American. I also have Caribbean and African immigrants as well as Hispanic patients in my practice predominantly. And what I see is that breast cancer is a different disease. It's seen in younger women, especially when we look at African American patients or patients of African descent. We know that it oftentimes is more aggressive. We know that there are different mortality rates which are higher for those patient populations. And so there's so much more that we do not know. And so for my patient population, I think it's a difficult change for me, because what we're left with is not doing clinical breast exams, not doing self-breast exams, and not doing mammography for women who are at the highest risk for mortality and the highest risk for breast cancer in the ages of 40 to 50. And so it's concerning to me, and I'm looking forward to there being hopefully an educational module that will help women identify whether they're normal risk. And will help us to look at additional information and data about other ethnicities in more data in more detail than we have currently to make those decisions.
All right, thank you very much, Dr. Wilson. So we have gone way over time, so that will conclude today's webinar. Thank you all for joining us. Dr. Wilson's documentary, Cancer, the Emperor of All Maladies. Do you know where they can access this documentary? I know there's a YouTube
there's
video
YouTube,
of
but
it.
it's on PBS, the PBS site.
Okay, so you can go to PBS and check out that documentary.
PBS.
Again,
Yep.
pbs.org. Okay, great.
Yes.
Great. It's Cancer, the Emperor of All Maladies. Again, thank you both for joining us. Thank you very much, Nicole and Dr. Wilson. And thank you all for attending today's webinar. Again, this webinar has been recorded, and it will be available on the Office of Minority Health YouTube channel. You want to check for the PPE playlist, and you can see all of our recorded webinars. They are transcribed as well. Thank you all very much, and have a great day.
Thank you.
Thank you.